Good morning, everyone. Myself, Dr. Shanmuga Priya Seshatri, Assistant Professor, Department of Pharmacology, SLIMS, Puducherry. Today's session, I will be discussing about histamine and antihistaminics. Objective of this session will be introduction to histamine. What is histamine? It comes under autocoids. So what are the different types of autocoids? What is autocoid and what are the different types of autocoids? And histamine comes under which autocoid? Followed by histamine receptors, which includes H1, H2, H3, and H4 receptors. There are 4 receptors. We'll be discussing about like where it is present, what is the action, and how histamine is synthesized, released, and distracted. Next, we'll be discussing about H1 agonist and H1 antagonist, that is known as antihistaminics, and the classification. Classification includes first generation antihistaminics and second generation antihistaminics. So we'll be covering the classification part of antihistaminics, followed by uses, where it is used. What are all the uses of first generation and second generation antihistaminics and the adverse effects of first and second generation antihistaminics. So this is the objective of this session need to be covered. Next, we'll start with the introductory part. Histamine is a autocoid. Autocoid means it's a local hormone, which means it is synthesized locally and destroyed locally, and it has a local action. Autocoid is a term derived from the Greek word which means self-healing substance or remedy. Autocoid are diverse substances produced by a wide variety of cells in the body. So what are all the cells we'll be discussing in the further slide, and which has a intense biological activity but generally act locally, that is within the inflammatory pocket at the site of synthesis and release. It is also known as local hormone because it is synthesized locally, released locally, and it has a local action. Autocoids are involved in number of physiological and pathological processes, especially reaction to injury and immunological insult. Some autocoids, in addition, serve as a transmitter or modulator in the nervous system, but their role at many sites is not precisely known. A number of useful drugs act by modifying their action or metabolism. So we'll be seeing what are all the drugs that acts and modifies their action or metabolism. Based on that, we'll be having the agonist and antagonist drugs used in different conditions. Next, we'll see the classical autocoid classification. So autocoids are classified into 3 types. First is amine autocoid, second one lipid-derived autocoid, third one is peptide autocoids. So amine autocoids includes histamine and 5-hydroxytryptamine, that is your serotonin. So histamine and serotonin comes under amine autocoid. The second one is lipid-derived autocoid, which includes prostaglandins, leukotrienes, and platelet activating factor. The third one is peptide autocoid, which includes plasma kinins, that is bradykinin and calidin, and angiotensin. In addition to this type of these 3 different class of autocoids, we also have cytokinins like interleukins, TNF alpha, GM-CSF, etc. And the several peptides like gastrin, somatostatin, vasoactive intestinal peptide, endothelins, and many other may be considered as a autocoid. So this is the classification of autocoids, and we need to know histamine comes under amine autocoid. Now we'll move on to the proper topic, that is histamine. Histamine is, when you divide this word, histamine, it is tissue and amine. Hista means tissue, min stands for amine. It's a amine autocoid. I told you before, there are 3 different types of autocoids: amine autocoid, lipid-derived autocoid, peptide autocoid. So our topic, histamine, comes under amine autocoid. So it is present in the mast cell as well as in the non-mast cells. So present in the mast cells, where it is present in the skin, gastric and intestinal mucosa, lungs, liver, and placenta. In non-mast cell, it is present in brain, epidermis, and gastric mucosa. Next, we'll see about the synthesis and destruction of histamine. Histamine is synthesized from L-histidine, So the enzyme responsible for the synthesis of histamine is decarboxylase, which means decarboxylase is the enzyme that converts L-histidine to histamine. So histamine is synthesized. The synthesized histamine will act locally and it get metabolized or distracted to a two metabolite, that is N-methyl imidazole amino acid and imidazole amino acid, with the help of two enzymes. One is N-methyl transferase and diamine oxidase or histaminase. So histamine gets converted to N-methyl imidazole amino acid by the enzyme N-methyl transferase. And histamine gets converted to imidazole amino acid with the help of an enzyme diamine oxidase, or also known as histaminase. So these are the enzymes responsible for the destruction of histamine. So this slide shows the synthesis and destruction of histamine. Next, we'll come to know about the storage of histamine. Histamine is always stored with the other thing, that is protein or heparin. Histamine protein combination or histamine heparin combination. It is always stored with the other protein or heparin when it is released. So we'll see when histamine it is released in two conditions. One is immunological release. The second one is chemical release. In immunological release, IgE and degranulation of granules. In chemical release, it can be because of mechanical or chemical injury. When there is a mechanical or chemical injury, there will be a release of histamine. And the drugs such as morphine, succinylcholine, and D-tubercularine are the drugs responsible for the release of histamine. Morphine is the opioid, succinylcholine and D-tubercularine is a skeletal muscle relaxant. So these drugs can cause the release of histamine. So these are the two conditions where histamine can be released, immunological release and chemical release. Now we'll move on to the histamine receptor. So far we have seen what is histamine. Histamine comes under autocoid. Which type of autocoid? It's a amine autocoid. Okay. And how it is synthesized, distracted, that is metabolite, and how it is released. Now we'll move on to the released histamine, where it is going to act. It is going to act on the histamine receptors. So we have four different types of histamine receptor, that is H1, H2, H3, and H4. H1 and H2 receptor are important uh, receptors for pharmacological action. H3 is the autoreceptor. H4 is studies like drugs acting on H4 receptor. The studies are under trial. Now we'll see about the each and individual receptor. First one is H1 receptor present in the smooth muscle will cause contraction. The released histamine acts on H1 receptor in the blood vessel, that is going to cause vasodilatation. Afferent nerve endings, it is going to cause stimulation. In brain, it is a transmitter. The agonist for H1 is histoprotein. Antagonist for H1 receptor is chlorpheniramine. We call it as CPM. It is most commonly used in the cough syrups. H2 receptor in gastric glands, it is going to cause acid secretion. In blood vessels, it is going to cause dilatation. In heart, it is going to increase the heart rate and force of contraction. In brain, it is the transmitter. The agonist for H2 receptor is dimaprid and antagonist for H2 receptor is ranitidine. So we will be dealing about H2 receptor in GIT because the most common action is in gastric gland. It is going to cause acid secretion. And the antagonist for H2 receptor is ranitidine. So this H2 blockers will be dealing in the gastrointestinal tract. When we go to that chapter, we'll be explaining about H2 blockers. What are all the H2 blockers? So in this session, we are concerned about the H1 blocker, that is antihistaminics. And we'll see a little bit about H3 and H4 receptor. H3, I already told, it is the autoreceptor. So it is present in the presynaptic region. The function is to decrease the release of histamine. Agonist for H3 receptor is emitted and antagonist for H3 receptor is thiopyramide. H4 receptor is present in eosinophils and neutrophils. The agonist for H4 receptor is emitted and antagonist for H4 receptor is thiopyramide. Now we'll move on to the pharmacological action of these histamines. In blood vessels, smaller blood vessels, it will cause marked dilatation. On subcutaneous injection, histamine will cause flushing, heat, increased heart rate, and cardiac output. In larger arteries and veins, it will cause constriction, that is H1 mediated action. It increases the capillary permeability. When histamine is injected intradermally, it will cause triple response. That is, red spot because of capillary dilatation, wheal reaction because of exudation of fluid, flower because of arteriolar dilatation. The point here need to be noted is histamine will cause triple response when injected intradermally. That is red spot, wheal and flower reaction. Red spot because of capillary dilatation, wheal because of exudation of fluid, flower because of arteriolar dilatation. In visceral smooth muscle, it will cause bronchoconstriction. Patients of bronchial asthma are highly sensitive to the histamine. On large doses, it will cause abdominal cramp and colicky pain due to increased intestinal contraction. So these two are mediated with H1 receptor. In glands, marked increase in gastric secretion is seen, primarily acid and pepsin. It activates H plus K plus ATPases, and this is mediated by H2 receptor, which increases the cyclic AMP. In sensory nerve ending, when histamine is injected IV, it will cause itching and pain. Pharmacological action in autonomic ganglia, it causes release of adrenaline that will lead to secondary rise in blood pressure. In central nervous system, intracerebral injection of histamine will cause rise in blood pressure, cardiac stimulation, behavioral arousal, hypothermia, vomiting and ADH release, antidiuretic hormone release. Now we'll move on to the pathophysiological role in allergic phenomenon. So far we have completed about the pharmacological action in various parts, and now we'll see the allergic phenomenon pathophysiological role. Histamine is one of the mediator of hypersensitivity reaction released from mast cell following antigen antibody reaction. What is released? The release is histamine is released from mast cell following antigen antibody reaction. It shows immediate type of hypersensitivity reaction. Histamine is causative in the following condition: urticaria, angioedema, bronchoconstriction, and anaphylactic shock. H1 antihistaminics are effective in controlling these manifestations. These manifestation means urticaria, angioedema, bronchoconstriction, and anaphylactic shock, except in bronchial asthma and anaphylactic shock, because these two condition is mediated by leukotriene and platelet activating factor. If you remember, leukotriene and platelet activating factor are also the autocoids, which comes under lipid-derived autocoids. One more is there. If you remember, I will tell you, it is prostaglandin, leukotriene, and platelet activating factor or lipid-derived autocoids. Next, we'll move on to the histamine uses, where it is used. As such, histamine is not having any therapeutic value, so it is used for skin allergy testing. For that also, the adverse effect is flushing, headache, bronchoconstriction, and intestinal cramp. There is the one drug called beta histidine, that is orally active histamine analog used to control vertigo in Meniere's disease, that is vasodilatation in the internal ear. So this is the example of histamine. Histamine as such is not used. It is used for skin allergy testing, and beta histidine is the orally active histamine analog used to treat vertigo in Meniere's disease. Now we'll move on to H1 antihistaminic. So far we have covered about the histamine, histamine receptor, histamine agonist, where it is used, pharmacological action, histamine agonist, where it is used, that is beta histidine to control vertigo in Meniere's disease. And we'll see about H1 antagonists. We call it as H1 antihistaminics. It is the competitively antagonism or action of histamine. The second generation are commonly used, which means it is a competitive blocker of histamine. There are two generations. We call it as first generation drugs and second generation drugs. We classify antihistaminics into two class, first generation and second generation H1 antihistaminics. Classification of antihistamine. So this is your first generation antihistaminics. We subclassify into highly sedative, moderately sedative, and mild sedative. Highly sedative drugs are diphenhydramine, dimenhydrinate, promethazine, hydroxyzine, and doxylamine. Moderately sedative drugs are phenyramine, cyproheptadine, meclizine, and cinnarizine. Mild sedative drugs are chlorpheniramine, dexchlorpheniramine, dimethylamine, tripolidine, cyclazine, and clemastine. So these are the drugs comes under first generation H1 antihistaminics. This is the second generation antihistaminics, which includes fexofenadine, loratadine, desloratadine, citracine, levocitracine, acylastine, avastin, rupatadine. So these drugs comes under second generation antihistaminics. Now we'll move on to the pharmacological action of H1 antihistaminics. It is the agonism to histamine, effectively blocks the histamine-induced bronchoconstriction, contraction of intestinal and other smooth muscles, triple response, and fall in blood pressure followed by low doses. If you remember what is triple response is seen with histamine injected intradermally. What is triple response? That is red spot, wheal, and flower reaction. The pharmacological action of H1 antihistaminics includes anti-allergic action, that is manifestation of immediate hypersensitivity or suppressed. It is used for urticaria, itching, angioedema, or well controlled. Anaphylactic fall in blood pressure is partially prevented. In central nervous system, the older one produces central nervous system depression. The older one means the first generation H1 antihistaminics are having CNS depression property. The second generation drugs are practically non-sedating. It prevents motion sickness. Promethazine is a drug that controls vomiting of pregnancy. It is also used to reduce the tremor, rigidity, and siluria in Parkinson's disease. The second generation are practically non-sedating, but it will cause mild sedation because of ability to cross blood-brain barrier. Anticholinergic action. Many H1 blockers in addition antagonizes the muscarinic action of acetylcholine. It has a local anesthetic action, phenyramine having a stronger local anesthetic action compared with other drugs. Other drugs have a very weak or less local anesthetic action. It also has membrane stabilizing activity. It is not clinically used as a local anesthetic agent because it causes irritation when injected subcutaneously. So H1 antihistaminics, even though it is having local anesthetic action, it is not used as a local anesthetic agent because of irritation property when it is injected subcutaneously. Now we'll see about the H1 antihistaminic pharmacokinetic action. It is well observed from oral as well as parenteral route. It is metabolized in liver and excreted in urine. Newer compounds penetrate brain poorly. The duration of action is 4 to 6 hours. Compared to first generation drugs, here the newer compounds means second generation drugs penetrates brain poorly. That's why practically they have very less sedation compared with the first generation antihistaminics. Adverse effects. First generation antihistaminics, they have sedation, diminished alertness and concentration, lightheadedness, motor incoordination, fatigue, and tendency to fall asleep. Dryness of mouth, alteration in bowel movements, blurring of vision, epigastric distress. All these are the first generation antihistaminics adverse effects of these drugs. Fexofenadine and cyclazine are the drug that will cause teratogenic effect in animals. All these adverse effects are frequent, but they are mild in nature. Second generation antihistaminics, they are higher H1 selectivity, no anticholinergic side effect. Absence of CNS depressant action is seen with these drugs, and they are longer acting drugs. Additional anti-allergic action, which inhibits the late phase of allergic reaction, that is leukotriene and platelet activating factor mediated reaction. Advantages and uses. It do not like this advantages and uses of second generation antihistaminics. They do not impact psychomotor performance and produce no subjective effect. Indication where it is used in the treatment of allergic rhinitis, conjunctivitis, hay fever, pollinosis, which controls sneezing, running nose, red and watering eyes. It is also used for the treatment of urticaria, dermographism, and atopic eczema. It is used for the treatment of acute allergic reactions to drugs and food. So these are the indications or advantages and uses of second generation antihistaminics. Now we'll see about the individual drugs. Fexofenadine. The drug fexofenadine, it is the active metabolite of terfenadine. Terfenadine is a drug that banned due to arrhythmogenic potential with CYP3A4 inhibitors. So it is not used in the market. This is the drug which also has QT prolongation property also. You need to know about what are all the drugs that will cause QT prolongation. Now we'll see about fexofenadine. Fexofenadine is the active metabolite of terfenadine. It is largely free of arrhythmogenic potential. It do not cross blood-brain barrier, so that's the reason where there is no sedation or impaired psychomotor performance. No anticholinergic side effect is seen. Loratadine, it is the longer acting peripheral H1 antagonist, and it is faster acting also. The drug which is acting faster and long duration, that is loratadine. This can be asked in your MCQ. Seizures are reported with few cases of seizures are reported with the use of loratadine. So I've covered two MCQs. One is it will cause seizures in few patients. It is a faster acting and long acting drug, that is loratadine. Desloratadine, it is a major metabolite of loratadine, effective in half doses. Citracine, it is a prodrug of hydroxyzine. It is more affinity for peripheral H1 receptor, penetrates brain poorly. Levocitrazine, it is a R enantiomer of citracine, effective in half doses, produces few side effects. Azilastin is a newer H1 blocker. It is a good topical activity. It has got good topical activity. Additional inhibitory inflammatory response triggered by leukotriene and platelet activating factor, and has bronchodilatory property also. It is used as a nasal spray for the treatment of seasonal rhinitis for a quick relief. So azilastin can be asked as a short note also. These are the newer H1 blockers need to know. Avastin is also a newer H1 antihistaminics. It comes under second generation. It converted to, all these things are second generation drugs, converted to carbastine It is the non-sedating one, active in nasal and skin allergies. Rupatidine, it is recently induced H1 antihistaminics. Additional platelet activating factor antagonistic activity is seen. It is indicated in allergic rhinitis. Uses of H1 antihistaminics. It is used in allergic disorders, controls certain immediate type of allergies, including itching, urticaria, seasonal hay fever, allergic conjunctivitis, and angioedema of lips. Anaphylactic shock and laryngeal edema, secondary place to adrenaline. In allergic disorders, it is ineffective in bronchial asthma because I already told you in bronchial asthma and anaphylactic shock, the mediator is leukotriene and platelet activating factor. Leukotriene, C4D4, and platelet activating factor are more important mediators in bronchial asthma. Concentration of antihistamine may not be sufficient to block histamine released locally in the bronchi. Other conditions involving histamine, insect bite, IV poisoning, prophylactic value in saline, blood-induced rigor. In pruritus, many conventional antihistaminics are used. It is the first choice of drug in idiopathic pruritus. In case of common cold, it gives the symptomatic relief by anticholinergic and sedative property. Newer drugs have less effective but less sedating property. Newer drugs means second generation H1 antihistaminics are less effective compared to first generation antihistaminics, but they have a very less sedating property. In case of motion sickness, promethazine, diphenhydramine, dimenhydrinate, and cyclazine are the drugs that is used for the treatment of motion sickness. It is given prophylactically. Promethazine is a drug which is also used in the treatment of morning sickness in pregnant women, drug-induced vomiting, post-operative vomiting, and radiation sickness. Cyproheptadine is the appetite stimulant action. For vertigo, cinnarizine H1 antihistaminic is used. Additional anticholinergic, antiserotonergic, sedative, and vasodilatory property is seen with this drug. As a pre-anesthetic medication, promethazine is used. For cough, three drugs like chlorpheniramine, diphenhydramine, and promethazine, these are the constituent of many cough remedies. For Parkinson's disease, promethazine offers a symptomatic relief in early cases. Acute muscle dystonia caused by antipsychotic and anti-dopaminergic drugs relieved by parenteral promethazine and hydroxyzine. As sedative, hypnotic, and anxiolytics, antihistaminics induces sleep, especially in children, and for promoting sleep, they are not dependable as sedative and hypnotics. So we have completed about the histamine and antihistamine. I'll summarize what we have covered in this session. So introductory part, we have completed what is histamine. Histamine is the autocoid. Which type of autocoid? It's an amine autocoid. And we have completed the how it is synthesized, stored, released, and destructed. So this completes the what is histamine, about the histamine part. And next we'll move on to the histamine receptors if they are asked in the question. So there are four receptors, H1, H2, H3, and H4 receptors. So where it is present, what is the action? Pharmacological action of histamine on these receptors need to be covered. When you start studying, you need to cover all these things like one by one, what like how I have taken the session. So after this introduction, receptors and pharmacological action. Next comes the classification. First is first generation and second generation. What are all the advantages of first generation and second generation? Second generation over first generation H1 antihistaminics. H1 like H1 agonist. What is the agonist? That one drug I discussed, that is beta histidine. Where it is used? It is used in vertigo to treat vertigo in Meniere's disease. And the next one is classification of antihistaminics, that is first and second generation, adverse effects of first and second generation, advantage of second generation over first generation, and then we'll come to the uses where it is used. And after adverse effect, we'll see the where it is used, and this covers the histamine and antihistaminic part. Now I'll discuss about the important questions in this chapter. That is, first one is uses of antihistaminics, side effects of antihistaminics, second generation antihistaminics, advantage of second generation antihistaminics over first generation antihistaminics. So this can be asked as a individual short notes, or it can be combined with the classification of antihistaminics and can be asked as a essay question also. Antihistaminics, it can be asked as a 5-mark, this last question, or it can be asked as a MCQ or like 2-mark question also. Antihistamines used for motion sickness or morning sickness. Which one is used for vertigo, acute dystonia and Parkinson disease? Antihistamines used for appetite stimulant. So I've covered the session with important questions also, and I summarized also. So this is going to be the end of the session. Thank you.